Yeah.
We are live now. So hi, everybody. Good evening. So today we are here with Jacques Ferreira, or Ferreira, like we say in Portugal. And we're going to have a really, really cool webinar today. So I would like to introduce you a little bit Jacques' CV. Okay, so Jacques graduated from the University of Pretoria in South Africa. He did first a Bachelor in Science in 2006, and then he went to veterinary school and he finished in 2011, right? He always liked anesthesia, right?
Yep.
So he decided to do an internship, and then he started a residency program in 2013. After this 3 years residency, he completed a master's in science and medical master's in veterinary anesthesia. In 2006 till 2018, he lectured veterinary anesthesia at University of Liverpool. And since 2018, he is at the private referral practice, Willows Veterinary Center and Referral Services, right? And is also one of our collaborators in anesthesia and pain management. So thank you, Jacques, for being here today. And I really hope you guys enjoy as much as me this webinar. Thank you. The word is yours.
Thank you very much for that lovely introduction. So as you quite rightly noted, I currently work in private practice and referral center. And the reason why I made this talk and why we often give the talk in this manner is because we often have a lot of advice requests on these two drugs, Medetomidine and ACP, or Acepromazine. And so I decided to just collate a few of the more common questions just to give a bit of a more explanation as to why you might have trouble with certain things and why you might struggle and when to decide to use one versus the other. So if I had to go and write down 5 of the most common questions we get on these two agents, it has to be which one is better at sedation, and we'll go into why there's an assumption that Medetomidine is superior to Acepromazine. Very importantly, how long does it take to work? Because very often when we're in a busy practice, we want it to work now / yesterday, and it's not working the way we want to. So we'll go over a look at the science and see exactly what it says and why we need to be a bit more patient possibly. And then what can we do to improve it when it doesn't work as we want to? This is something we get a lot, particularly in your more aggressive patients or dogs that are very scared why the Medetomidine isn't necessarily working the way you want it to. And then we'll talk a little bit very briefly about what do these two agents do in patients that have maybe less than ideal cardiac function, and I can hopefully give you a bit of guidance as to when you should use one or the other or none at all. And then finally, just because there is so much, brachycephalics are now at least making up probably 50% of our work at referral level. And so how do we go and sedate these safely, and which of the two agents should we use? And I'll show you some videos to describe the effects there. So if we go look at which one provides superior sedation, I think it's pretty much a given that everyone would say Medetomidine is considered the superior of the two, or more profound, the sedation. But interestingly, if you go look at the studies that were done comparing these two agents, it was not as definitive as what we think we see in our clinical practice. So why might that be the case? So here's an example of an article that was comparing Acepromazine to xylazine, this was in earlier days before Medetomidine, but it's effectively the same thing. So it's an alpha-2 adrenergic agonist. And they wanted to have a look and see what was the effects on the sedation, as well as certain physiological adaptations that would happen within the animal. And in this particular study, they compared the use of methadone to see if it had a potentiating effect or not. So what did they find? So the first thing they found was that the xylazine and the ACE methadone seem to produce very similar levels of sedation. So in this table, they've got 4 groups, or they've got the methadone-only group, the acepromazine, the xylazine, the combination of methadone, acepromazine, and xylazine. And then they basically scored them for the level of sedation over time. So we got baseline values before the agents were given, and then every 15 minutes up to 90-minute period, they went and they scored them accordingly. And if you have a look here, the first 15 minutes, xylazine was superior to the acepromazine in these 2 groups, and it was the same when it was given alone. But if you give acepromazine enough time to work, it almost catches up. So at 30-minute mark, they're getting a little bit closer together. And you can see the methadone is helping the medetomidine, the ACP a little bit here. So they're 2 and 2.5. So the higher the number, the more sedate. Around 45 minutes, when acepromazine would be working at its most effective, we're almost, we've gone backwards. There we go. We've almost reached a level where they're equivalent. And then at the 60-minute mark, they're exactly the same. So what do we learn from the study? The first thing we learn is that the degree of sedation is almost equally matched when it comes to the 60-minute mark. However, if you're in a rush and you give them at exactly the same time, you're not going to see the effect of acepromazine within the first 30 minutes to the same degree as the xylazine. Now, we're all clinicians, hopefully, listening to this. We all know that 30 minutes is a long time that we don't necessarily have. But the reality is this is the way that the drugs are designed, and we have to give them enough time to work. So I thought that's a really interesting study. Then they did another study where they wanted to see if they compared acepromazine with medetomidine combined with buprenorphine. And they use buprenorphine because it's not known for its sedative properties. So you can give the drug in combination and it shouldn't have any other effect on those two drugs in terms of the level of sedation. So what they did is they administered these and they had to look to see if which one was provided more sedation than the other. And actually in the study, they were unable to see a significant difference. So how is that possible? It's surely medetomidine is superior. We see it all the time. There's two things here that I think have to be highlighted as to why this is the case. The first is both those studies were controlled conditions, and controlled conditions take a big thing they remove a big element of our daily practice, and that is fear. So in any controlled study, you're always going to have patients that are habituated to the environment in which you perform the test, and they're habituated to the person who's going to perform the test on them. So in this case, it's how sedated are you? So if I walk into the room, but you know who I am, the level of anxiety you're going to have is much lower as the dog. The other thing that's important to remember is medetomidine is a patholytic, and that's really just saying that the autonomic nervous system is made up of parasympathetic, or the rest and digest, and the sympathetic nervous system, which is the fight or flight. Now, medetomidine has a little bit of an extra weapon compared to acepromazine, and has the ability to switch off the fight or flight response to a degree. Now, how does it do that? And it does that by basically this. So this is if you can imagine, this is a synapse between two nerves within the autonomic nervous system. So when an animal is particularly stressed, there will be an increased activity at this level, and there'll be an acetylcholine that's going to be released from the top end and go all the way to the bottom to the alpha receptor. Now, this is happening in the brain. It happens in all the various organs. What medetomidine does is it tends to bind over here to this alpha-2 receptor, and it acts as an inhibitor of the negative feedback loop. So what essentially happens is it switches off the ability for the nervous system to work. And so in a competitive manner, so long as there's enough medetomidine around, it should allow for the sympathetic nervous system to be switched off. However, it's a competitive inhibition. Basically, that means there's a neurotransmitter and there's a drug competing to bind at the same site. So in a very stressed animal that's releasing a lot of endogenous catecholamines from the presynaptic level, they are going to outcompete the drug. And that's what you're seeing in these very scared, very anxious animals. You're starting to see that they produce so much adrenaline, noradrenaline, and other catecholamines that they have the ability to actually push your medetomidine drug off of the receptor, and so your sedation is overridden. And that's something to remember. So how can we improve things then? So if we've got a problem where we've got a competitive inhibition at a receptor site, we can do one of two things. We can add an opioid that's going to cause an increase in sedation. And how does it happen? Well, actually, if you had to go look at a molecular level, that alpha receptor that the medetomidine binds to is almost essentially the same as an opioid receptor. It has something called a G-coupled protein. It's not important, and you never have to remember this. But what happens is these two, when these two drugs bind to their receptors, they switch on these G proteins in the same manner. And so they act on us as a synergistic way. And as a bit of advice, giving atipamezole will also switch off these receptors and G-coupled proteins. So you be careful. If you completely antagonize a painful patient, you will reduce the effects of your opioid in them as well. So it has the same effect when both ways. So there's another way to get around this. If you've already given an opioid in your pre-med and the dog is going to be really aggressive and override this because there's still the ability for the competitive inhibition to work, you can combine a drug that's not necessarily going to have any effect and have to compete at the same site, and that's probably ketamine. And this is because it inhibits the sympathetic nervous system in a non-competitive manner. So how does it do that? Well, ketamine binds to something called an NMDA antagonist. And the NMDA antagonist is found in various different parts of the central nervous system. But what's so good about it is it has the ability to switch off your sympathetic nervous system right in the very central components in the brain. And when it does that, it has the ability, it doesn't matter then if your presynaptic release of noradrenaline and adrenaline is high, because effectively there is going to be no presynaptic membrane firing from the beginning, because at the central level, the ketamine has switched it off. And so here is where a great combination such as ketamine medetomidine worked in combination seems to override the very stress and fearful animal. So that leads us to another question. If we need to produce more sedation, should we just increase the dose? And is that the same for ACP as well as with medetomidine, just increasing the dose increases sedation? So the question is, what is an effective dose, first of all? So in 1998, they went and they looked at a dose titration study. So what they did is they took 5 different doses, 1 microgram, 2 microgram, 5, 10, and 20 micrograms. They administered intravenously and they scored the level of sedation. And this is from the paper. It said, surprisingly, based on the subjective sedation score, a moderate level of sedation was observed even at a very low dose. So even 2 micrograms per kilogram was effective. Furthermore, deeper sedation was obtained only with the largest dose in the study, compared with the 2, 5, or 10. However, the duration of sedation is clearly dose-related. And this is what we see in clinical practice. You can achieve a whole lot in terms of sedation with very low doses of medetomidine. And we routinely, in our patients at referral level, use doses in the region of 3 or 4 micrograms per kilogram as a pre-medicated dose before they go for an induction. And even if we need to perform an ultrasound, we don't exceed 10 micrograms per kilogram because that's all we need. Conversely, if you have to increase more and more and more, even if you go up to 20 micrograms per kilogram, you're going to get a certain level of sedation that's maybe more profound. But after that, all that's going to happen is that the duration is going to extend. So if you're not going to suddenly be able to perform more invasive maneuvers with the patient, for example, a patient that's very painful while doing hip extensions for x-rays or radiographs of the hip joint, particularly in a painful patient with hip dysplasia, it's not going to be of any benefit to provide more medetomidine because it's not a long procedure. You just need them to be sufficiently sedated. And that's when maybe using a different agent such as ketamine, which switches off a sympathetic response and provides pain relief, will be, in combination with the medetomidine, be sufficient. So that's really interesting. So what about acepromazine? So acepromazine in conscious dogs, they went and they looked at different doses. So if you go look at early literature before the 1990s, acepromazine was used at very high doses, even up to the point of using a 0.1 milligram per kilo or 100 micrograms per kilo, which is you can see on this histogram on the far right. So what they did is they used 4 different doses here, and they gave it to the dogs, and they had to look to see what the level of sedation was. And so they used something called the number of dogs to achieve a specific score. And what they realized was even at low doses, so ACP of 0.01 or 10 micrograms per kilogram was effective to provide a level of sedation to around 1. And 25 micrograms per kilogram, you provided a little bit more sedation, so that you can see it's white. But then afterwards, no dog, no matter what you gave, whether it was 50 or 100, had a sedation score that exceeded the 25 micrograms per kilo. So pretty much all the dogs were at 25 micrograms per kilo were sedated to a score of 2. all of them at 50 and 100, but none of them went to 3. So it didn't improve things significantly in level of sedation. And so the conclusion of the study was that there was actually no benefit to increasing your dose beyond 25 micrograms per kilogram IV. It's not going to improve things at all. But what you will see, conversely, with increasing doses, is you're going to see more systemic effects. And remember, we'll go into this a little bit later, but acepromazine is a potent vasodilator. Well, is it? We'll have a look at the literature, but you're going to basically inhibit the cardiovascular system more than provide sedation once you exceed these doses. So what about the time to peak effect? So we had a look at acepromazine. We saw in the previous study that you need to give 45 minutes to 60 minutes to see the effect. So what happens with medetomidine? So here's 2 graphs. They've got the total sedative score on the y-axis, and on the x-axis time. And what they basically did is they had a look at the level of sedation that the dogs were scoring over time. And they split them into 4 groups: medetomidine or dexmedetomidine. And you can see that there's really no difference. And then medetomidine, when they then gave an acipamazole dose. So how quickly did the sedation scores become reversed? So for the process of this study, we're going to look more at the red and the blue graph, these lines on the graph. So here's some interesting. So on the right was intramuscular graph, and on the left is intravenous. And if we look at the time to peak effect in the intravenous group, it was around 15 minutes. How many of you have given a pre-med of medetomidine before induction and waited 15 minutes? I can't say I have. And this is the problem. We don't wait long enough to see the peak effect. And so we start adding more and more, thinking that it's going to improve, but we probably haven't given the drug necessarily enough time. What's even more scary is if you look on the right, you've got the intramuscular group. Time to peak effect of medetomidine and dexmedetomidine. And here you can see a slight split. And there is another study that has shown that maybe medetomidine is slightly superior when given intramuscularly as a sedation. And that seems to be, you can see this differentiation here. But time to peak effect intramuscularly is 30 minutes. Very often when we have our nurses sedating the patients to go for an x-ray, for example, we'll get a phone call to say that the dog is not sedate enough. And the first thing I'll ask them, if it's given intramuscularly, how long has the time been? 9 times out of 10, it's over here. It's before 15 minutes. And they say, nothing is happening. You need to give more. And the first thing I'll say is wait till 20 minutes post-injection, because you'll be in this range. You'll be in the range here where you've got pretty much your efficacious peak. And then if the dog is sitting up wagging its tail at 20 minutes, it's unlikely it's going to improve to the point that you can go off to your x-ray. So there you validated to go and to add some more. But if you've come before 15 minutes, you have no idea where on this curve you are, and you probably haven't waited long enough to see the maximum effect. So to summarize from a sedation point of view, medetomidine is effective at low doses. I think this is a real good take-home message. 1-2 micrograms per kilogram is an effective dose for sedation. Increasing the dose upwards of 20 micrograms per kilogram is going to only increase the duration of the sedation. It's not necessarily going to increase the degree. You need to, if you are really concerned that you need to provide enough sedation and it's not working at 20 micrograms per kilogram, you're going to get more benefit from adding another agent to your mix, such as ketamine, or if you haven't added an opioid such as methadone, you would consider this, or butorphanol if it's a non-painful procedure. Acepromazine, and this is something I stick to in my patients, I don't exceed 25 micrograms per kilogram because it's actually not going to provide any more level of sedation. It's just going to cause cardiovascular derangements that I'll have to go and manage later on, particularly under general anesthetic. But what's so important is allowing enough time for these drugs to work. 15 minutes for IV is quite long. 30 minutes for max effect in IM, it gives you a real, it just drives home the message that we need to be more patient, or we need to start these procedures slightly earlier from a pre-med point of view, or particularly intramuscularly, to allow for that peak effect for when you need it, for whatever you're planning to do. In stressed animals, medetomidine is superior when it compared to acepromazine, but it can be ridden in very fearful animals or very sympathetically driven animals, so stressed animals or painful animals, and you need to consider adding another drug on top. Right. So what about in your patients with heart disease? First thing I want to bear in mind is just there's two things, the cardiac function, that you need to concepts you need to think about and consider when we talk about these drugs. The first is that blood pressure is the difference between the peak pressure on the arterial side and the venous pressure on the right side, in the venous system, or the right side of the heart. And it's the difference in these pressures that will drive blood from the left side around the body to the organs and then back through the right side to return to the heart. Very important, we appreciate that. Now, how much blood you move around in any one beat to your various tissues is known as cardiac output. And you have to have both of these working efficiently to deliver enough oxygen to the muscles to allow for the normal metabolism, and of course for all the organs, the normal metabolism for them to function. And certain organs will always be more susceptible. The most susceptible, myocardium, has an extraction ratio of 60%. That means every time a red blood cells move around the coronary perfusion, they will leave the coronary perfusion with at least half the blood has been deoxygenated at that time. So that's very, very high oxygen demand. Kidneys, also very high oxygen demand. And then the brain. So these are the organs we're really thinking about when we want to maintain good cardiac output, so enough oxygen to them, as well as enough blood pressure for them to get there and back to the heart, and then the lungs to be refreshed with oxygen again. So whenever those two are not working sufficiently, there's going to be issues. What's also important is don't just try and drive home for high blood pressure, because eventually, if you try to create enough pressure difference through vasoconstriction, so blood vessels are getting smaller on the arterial side, you will eventually impede how much blood flow goes through there and how much blood flow goes to the different organs. So you can't just chase blood pressure alone without thinking about cardiac output, because you'll end up in trouble. So the cardiovascular effects. To create a cardiac output, you need two big things to happen. You need to have enough blood volume ejected from the left ventricle during contraction. So one heartbeat, boom, blood leaves the left ventricle, goes around and joins the arterial tree and goes to the arterioles, to the capillaries. The number of times that this happens per minute is the heart rate. And therefore, for every volume of blood leaving the left ventricle, let's, for example, erroneously say 100 mils, if there's 60 beats per minute, that's 60 times 100, it's 6,000 mils that would leave, or 6 liters a minute, for example. That's what cardiac output is. So if something drops your heart rate, it's going to directly affect your cardiac output, proportionally so. So a proportional drop in heart rate. So if your heart rate drops by 50% out of nowhere, your cardiac output may definitely drop by 50% if the stroke volume doesn't increase. So if heart rate drops, you need your ventricle to pump harder. That's all fine and well in healthy dogs, but in dogs that are not healthy, the ability for them to make that adaptation, such as increasing contractility of the left ventricle, may not be there. And these is where you can run into quite a lot of trouble. And that's when you can start having all sorts of shock or hemodynamic shock or various derangements. So here are the cardiovascular effects of acepromazine and medetomidine explained very well. So on the left, you've got mean arterial blood pressure, and on the right graph, you've got cardiac output. And on the x-axis on both sides is the time. And you can see that these patients were awake at time 0, and then they were administered a propofol, so that's a P. They were then GA'd using isoflurane, and then they were recovered. And you can see a very big split here in the blood pressures. So unsurprisingly, the triangle line is the medetomidine line. So the blood pressure has gone up significantly from a mean of around 90 at baseline. Then they administered the medetomidine just before the propofol, and the blood pressure went all the way up to around 110. After administration of propofol, there's a bit of a drop, and then the isoflurane, once you put your dog on isoflurane, you can see there's quite a precipitous drop. And what's going on here as well is you're starting to see the waning effect of the medetomidine. So that vasoconstriction that was there at the first time check is now starting to disappear. So you're getting more and more vasodilation on top of the vasodilation from isoflurane. Remember, isoflurane is a vasodilator. And so once they've stopped the anesthetic, so isoflurane has effectively been stopped, and it's leaving the body, then the vasodilation effect of the isoflurane disappears, and then you start seeing the blood pressure rise. Now, when you look at ACP, you can see what's happened on the general anesthetic. So here, you've got your ACP being given, a little bit of a drop. You give them an induction agent, you put them on isoflurane, and there's a huge drop off here. Look at this. So your mean arterial blood pressure is around 50. And it sits there until you eventually switch your isoflurane off, and it comes all the way back up. So that's the mean arterial blood pressure. That makes complete sense. That's what we as vets understand, and that's why we use the drugs in the manner that we do. But now what happens with cardiac output? So cardiac output, remember, is the number of liters per minute that leave the heart to provide enough oxygen to your muscles. Medetomidine is really good, actually. It seems to maintain enough cardiac output to really stay within a normal limits. And how has that happened? Remember, the vasoconstriction of the medetomidine is sort of going to work against the isoflurane vasodilation. And then, so they can keep a relatively good maintenance of the cardiac output initially. And then as the heart rate starts increasing a little bit, you'll find as medetomidine starts wearing off, heart rate will increase a little bit and probably match the drop. And so your cardiac output stays fairly level. So it's something to remember, actually, that the medetomidine works really well when it's under general anesthetic because of the vasodilation effect. Cardiac output, though, with the ACP dropped precipitously during the propofol. Propofol is a massive vasodilator. So when they were dropping all of this, there would have been a vasodilation effect. And one of the additional effects of propofol is it doesn't allow the heart rate to come up in response. So as you get vasodilation, you won't see an increase in heart rate with your propofol administration, just sits there. Over time, the propofol disappears. So 20 minutes after you've given propofol, it's not really there anymore. And you can see there's starting to be a rise up again as all the effects of the propofol are wearing off. But the isoflurane and the ACP in combination are still creating enough of a drop to drop the cardiac output, but heart rate's picking up and allowing a bit more of an increase over time. But as soon as you switch off and you allow the isoflurane to leave the body of the dog, then it should improve, but it doesn't as much. And that's because the ACP is still there. I'm not entirely sure that these values are accurate as much as there would be, and I'll show you some interesting data that came out a few years ago that sheds a little bit more light on this. So this is a study that came out in the Specialist Anesthesia Journal just, I said last year, it's now 2 years ago. And they went and they had a look at the effects of ACP when given under general anesthetic and given in patients that are awake. And they used a little bit more invasive monitoring than that earlier study that was done a good 15 years ago. And what you can see here, so there's all these variables, but there's three I want you to look at. This one, which is basically the amount of vasoconstriction. So what is the systemic vascular resistance? So how much vasoconstriction or vasodilation there is. The higher the number, the more vasoconstriction. The lower the number, the less vasoconstriction is how I would explain this. And as you can see, as they give ACP under general anesthetic, you're starting to see a drop off in the amount of vasoconstriction over time and at higher dose rates. Stroke index, which is telling you about basically how well the heart is pumping, seems to remain pretty solid there. So stroke index is increasing, stroke index is increasing, stroke index is increasing. So it tells you that the heart's tried to compensate for the vasodilation by rejecting more blood out. And that's what we sort of understand with ACP. But when you look at it in a conscious patient, there were some really interesting things. Here, this is delivery. This is basically cardiac output, delivery of oxygen. Over time, there's a drop. And what they saw in these conscious animals was that it wasn't related to the vasoconstriction that you would be expecting. Wait, let me go back. Pressing the wrong buttons. What they realized is that actually, in a conscious animal, for whatever reason, acepromazine actually seems to affect the contractility over time. When they're under anesthetic, such as isoflurane, the vasodilation actually helps the heart pump. So there is this compensatory increase in cardiac contractility that you saw in the previous slide. But when the patient is awake and there's sufficient vasoconstriction to work against, it's almost as if ACP has stopped the contractility so much that it drops off the blood pressure. And so you need to bear this in mind, that it's not the vasodilation in a conscious animal, it's actually an inhibitory, an negative inotrope, which is not how we learned about ACP, and it's not how we think of ACP. So we need to just bear that in mind. So from these studies, what we can tell, there is a dose-dependent effect on cardiovascular. And here, this is a great example of dose dependency on cardiac output. So this is cardiac index, again, liters per minute per meter squared, which is a smart way of saying cardiac output. And they've basically looked at medetomidine in different dose ranges. So 1 mic, 2 mic, 5 mic, 10 mic, and 20 mic. What you can see here is the drop over here is worse in the higher studies, in the higher doses. So 10, 20 drops it significantly. But even 1 microgram per kilogram over there in the square box has dropped the cardiac output sufficiently from baseline, which was up here. And that's what we see. And that's why we have to be so careful. In cardiac disease, even if you give 1 microgram per kilogram, you are going to reduce your cardiac index significantly. And you have to be careful in these patients. So if you've got a patient that has what we would call a forward failure, so the ability to push blood from the left ventricle out into the body is insufficient, you would be concerned about using high doses. But even if you avoided the 10 to 20 microgram per kilogram dose, you're still going to have a relatively profound effect. What is quite noteworthy here, though, is the 5 microgram per kilogram is almost sitting on top of the 10 and 20. So even 5 micrograms per kilogram produces the same level of impedance as the higher doses. And so in cases where we were unsure, or young patients where we think cardiac output may be affected, we would never exceed or go up to 5 mics for that reason. So we might even tolerate over here because you are getting a precipitous drop, but at least there is a differentiation in how much cardiac output has been affected. So near max cardiovascular effect is 5 micrograms per kilogram IV. That's a real take home. And at that point, you're going to affect oxygen delivery. But both drugs can do this. I think this is what's so important. And in ways that you wouldn't necessarily think so, as in with the inotropy effect in the ACP. While ACP does predispose to vasodilation-induced hypertension under general anesthetic, we seem to think that in conscious patients, it's myocardial contractility that's an issue. So beware of using this as in a stressed patient sitting in your ward or in your kennel, and you think, I'm just going to give him a little bit of ACP. He's got a bit of a bad heart, but it's okay. ACP is good for the heart. It's not always the case. It seems to actually be causing myocardial contractility issues. And then ACP does significantly reduce hemoglobin concentrations. I know we didn't go into this too much, but this becomes a bit of a factor when you're delivering oxygen at tissue level. And the take-home message here is be careful in patients that have low hematocrits. ACP has been known to reduce arrhythmias, although I wouldn't use it as specifically arrhythmogenic, but we do know that medetomidine increase arrhythmias, and that's more than likely secondary to the high vagal tone and the sympatholysis that we spoke about earlier. So just bear that in mind. You're likely to see your VPCs with that. So can we use these drugs in cardiac disease? I'd say if in doubt, you're not entirely sure of the cardiac function, you would probably stick to very low doses of medetomidine, not exceeding 5 mics. Even 1 to 2 is somewhat, you have to be quite cautious. And again, ACP, I'd be cautious as well for this reason. What I would say is lean on your opioids in these cases. So if you want to use a cardiac case, lean heavily on your opioids. Use butorphanol at a much higher dose than you would ordinarily. 0.4 milligram per kilo is something that we use quite effectively in these patients where we're worried about cardiac disease. And using the high opioid dose alongside very low amounts of your ACP or acepromazine and your medetomidine allows you to judge what the level of effect you're going to get. If you suddenly get a profound sedation from almost just butorphanol, you know that the cardiac function is relatively affected, and don't push any other pre-med from there. Another thing to bear in mind with cardiac cases, if you're unsure, a general anesthetic may be preferred to the sedation that you wanted to originally give, even if it's a short procedure, because you can use lower doses of these agents or avoid them completely. You can also provide 100% oxygen. Remember, cardiac output is important for delivering oxygen to the tissue. So if you can provide enough oxygen in the beginning, supersaturate, you're likely to provide more oxygen. And then there's better monitoring. As an anesthetist, we like to see the numbers, we like to see the trends, we like to know what's happening at different levels in the body, tissue levels, lung levels. So when in doubt, we all GA a patient rather than sedate them, because we can monitor them a whole lot more invasively. And if you're not entirely sure, use the opioid as your mainstay of your pre-med. So what about medetomidine in brachycephalics? We get inundated with a lot of phone calls for advice requests on how should we proceed with brachycephalics coming into the practice that we need to sedate for such and such, or to go for a surgery because we're worried about the upper airways. And it's a noteworthy consideration. And one of the reasons why we think medetomidine is being avoided, particularly as a pre-med, is that it is a central muscle relaxant. So it's going to relax the muscles, and everyone's really worried it's going to occlude the upper airway. But what we haven't necessarily brought into account here is the level of stress the brachycephalics are under when they arrive at your practice. And what is the contribution of stress to the overall clinical picture that you're seeing versus the severity of the brachycephalic airway disease. And this is where it becomes really interesting. So this was something I actually added to the presentation only a few days ago, because this guy came in and I thought this is a great example of what we normally see. Hopefully you get the audio will work. So listen to that bad boy. Come on, buddy, make some more noise. There's a lot of. So he came in for hemiparesis. He's got a thoracolumbar disc. He came in with a high temperature. He was really stressing out. We were concerned that he was going to obstruct. The neurologist wanted to push him earlier into the queue for an MRI. And so I had a look at him and decided what to do. So I do have to excuse the background chatter. Our nurses generally love to talk, and it can be quite loud, but have a look at that again. That is a significant amount of upper airway strata. Right, so that was our dear friend Lenny. So what did we give Lenny? We decided we're going to give him 15 mics. So remember those low doses of ACP? I gave even lower and I gave it IM. So 0.015 milligrams per kilogram IM. We then decided we're going to move him to ICU for some monitoring, just in case he did obstruct. But what we decided, rather than to put him into a kennel where he would stress more, we found a nice comfy bed and mattress. So we put him in on the floor, out the way, obviously. And we decided, I'm going to switch Lenny's audio off. And we then decided to put a fan on him to cool him down. Okay, so that was on presentation. So this was Lenny 40 minutes later. So still got the upper airway strata, still very much paretic, still got his thoracolumbar disc, but he's a lot more relaxed. Lenny's loving life. He's curious, he's inquisitive, he wants to know what's happening. He's not so worried about the fact that he has a terrible snore. And that's just with that little bit of ACP on board and a little bit of time. So the question is, do we need to give him anything else? Should we give him medetomidine? So I did. I was going to give him some medetomidine before he went into his MRI because it has significant benefits and remember that maintenance of the cardiac output and the blood pressure. I like those trends under general anesthetic, so I was going to give him some anyway. So this is 15 minutes after I gave Lenny his medetomidine, and there's only 5 mics. Again, IM alongside methadone. But look at him, he's relaxed, he's not obstructing, he's not stressing out. He didn't like having an IV put in, so we went IM, and he's just all relaxed. He's really happy. He's got a big snore, but he had a big snore when he came in anyway. His upper airway strata is there. But there's no big airway occlusion or a respiratory emergency. And if anything, he's more relaxed. So to summarize, the use of both these agents provide notable benefits. I think the use of these drugs are great, and we shouldn't be too scared to use them. I think very much how I would decide what to use, where and how is based on the level of anxiety and the health conditions. If you have a dog that's suffering from a known cardiac disease, you're going to decide on whether you want to use both these drugs or none of these drugs at all. But you're going to invariably use them at lower doses. Medetomidine is effective at very low doses. Your 1 to 5 micrograms per kilogram, even in healthy dogs that are stressed, will provide notable sedation. So don't be afraid to start slower. I often say to residents or other clinicians when they ask why we give a low dose first, I say, I can always give more. I can always give more drug, but one I can't do is take away drug once I've given too much. What I find is ACP works very well as an anxiolytic. However, the benefit doesn't really become any better when you increase the dose beyond 25 micrograms or 0.025 milligram per kilo IV. And so I just don't see any benefit to going above that. And so I would advocate considering changing those protocols if you've got them on very high doses, because you're probably not going to achieve very much in the way of sedation other than cardiovascular derangement. And then finally, don't be afraid to use medetomidine in brachycephalics, but you can reduce the dose and still have an effect. But I think what's really important in these patients is providing the environment to allow the drug to work. In this, the videos that I showed you, it was Lenny being relaxed on his bed. That probably aided in really allowing the medetomidine to get on board, or the ACP to work as well, and to allow him to have the benefit from those very low doses. And that's it.
Okay, thank you, Jacques, so much. It was amazing. I learned a lot. We do have one question. Is it okay if I ask you from a colleague of us that were live with us?
Yes, of course.
So, João Paulo asked, so if ACP has a negative inotrope effect, should we use concomitant inotropic drugs like Premedication or atropine? Do you recommend them?
I think it's a good question, actually. So in your cardiovascularly compromised patients where you think forward failure is an issue and you need to provide Premedication. Remember, Premedication is a positive inotrope. It's got a number of other benefits, but its mainly is it improves contractility. I think if I needed to give an inotrope, if that's how bad it is, I would probably avoid the ACP, because I would, in all likelihood, use a much higher opioid, and I would maybe change my induction agent. I think what's important to appreciate is that rather than selecting the ACP and then having to give a cardiovascular drug, if that's what you need to make a decision to, rather leave out the ACP, if that makes sense. And then the other thing to remember with atropine speeds up the heart rate, which would increase cardiac output. You're quite correct. So if you've got a contractility issue and you had to use atropine, you would increase the cardiac output. However, atropine forcing the heart rate up can sometimes increase the myocardial oxygen demand. So we just have to bear in mind that to try and achieve global cardiac output is good, but we sometimes can result in a mismatch at the level of the heart where the coronary perfusion may be affected. And so for atropine, if you had to do it, you would use a far lower dose than what maybe you used to. So a normal dose is 0.04. You would maybe use half of that for atropine. And then the other thing to consider with the PEMA would be you'd obviously have to use an injectable if you did decide to use it. And we have sometimes had that where we've had a cardiac scan and we think, okay, this cardiac function is not great. And you give it IV and it does improve.
Okay, thank you so much, Jacques. It was great. I thank you one more time for being here with us with this amazing presentation. And I hope to see you soon again.
Thank you. Thanks very much.
Thank you all for watching. Bye-bye. Take care. Bye.